So three types of devices are used for ventilation. You have the self-inflating bag. You always need to have a self-inflating bag by the bedside in case of emergency, like you need to move the baby where there is no gas flow, like a fire hazard and so on, or when you are losing gas supply during the transport. So always keep the self-inflating bag in the system because it's very useful from this point of view if there is no gas flow. The other two devices both need a reliable gas flow. Preferably an oxygen blender should be an essential part of the resuscitation equipment. So the T-piece resuscitator is mainly preferred because we have the PIP and the PEEP, both can be regulated. You can also adjust the inspiratory time according to how long you press it. So the rate, rhythm, everything is better controlled. As I said, the only advantage of the bag mask with a self-inflating bag is the quick increase in pressure that you may do if the baby's chest is stiff. But the disadvantage is obviously that you don't monitor the pressure unless you have a manometer, and you may give excessive pressures. Laryngeal mask airway, if the baby cannot be successfully ventilated with a face mask and intubation is unfeasible, then you may use laryngeal mask. So we have also discussed that the laryngeal mask is preferred in the NICU scenarios as well if the baby needs ventilation for longer than a few breaths. So there is less leak, the effectiveness is better, and you may more successfully resuscitate. If the ventilation with the mask is prolonged, many times we see that the seal loosens up and you may need to keep adjusting it. So keep an eye on that. So if you continue face mask for a longer time, orogastric tube should be inserted to act as a vent for gas in the stomach. Otherwise, you will get gastric distension, which pushes the diaphragm up. It will collapse the lungs more and make it more difficult to ventilate the baby. So this is the laryngeal mask airway. Different types are available. Most of them are the size 1, the size 0. We are awaiting it, which can be used in babies up to 1 kilo. Many people have reported even using this size for babies 1.5 kilo or so, though the license is about 2 kilos. And this is how it will sit in the airway. This is the opening of the larynx, and this will just sit over it. So gastric distension is reduced. It's more effective, and you can even give surfactant through a feeding tube which is inserted if there is a separate port. That's called SALSA. So unlike in older children and adults, the direction of insertion is the natural way. You don't revert it, and you put it in and push it till there is resistance. Then you inflate if the model needs inflation, and then secure it as you would secure an ET tube.